Hi, this is Vaibhav Vaidya with the Fits on the Go blog here at AHA 2015 in Orlando, Florida. We're joined today by Dr. Bernard Gersh, Professor of Medicine in the Cardiology Division at Mayo Clinic. Thank you for joining us, Dr. Gersh. We're going to discuss the results of the SPRINT trial, which was huge news yesterday. 9,000 patients randomized to two different strategies of blood pressure lowering, less than 120 millimeters of mercury versus less than 140 millimeters of mercury, and significant differences in the outcomes as we'll discuss. Dr. Gersh, what do you think are the implications of the SPRINT
Well,
trial for our practice?
I mean, it's a huge trial, and I don't even think we fully understand the implications at the moment. As you know, there was a certain lack of suspense because we knew the results 2 months ago when the trial was stopped prematurely, but due to a significant difference in events. Personally, it kind of reinforces my own preconceptions of where blood pressure should be. And I think the implications are huge in that the recent guidelines have been very controversial. I mean, they've advocated much higher target levels of blood pressure. So this really changes it. So in terms of the implications, the first one is, will the guidelines change? And I think it's going to be very interesting to see. And I suspect that they will. I mean, this is very convincing. The second implication, though, is we have to realize that treating and getting blood pressures to 120 is not a simple task. I think in this trial they were on 3 medications. We know that people don't take their antihypertensive drugs. I mean, there's a huge compliance issue with hypertension. And in fact, it's related to the number of drugs they take. At least some studies have shown that. So now you committed to 3 drugs, and so compliance is a major, major issue. I think the other aspect of this trial, which is a little bit unanswered, is what do you do with a patient in their 80s with a blood pressure of 180? Are they going to really tolerate going down to 120? And those patients, I don't think were really in this trial, severe hypertensives. And as you know, in the trial, there was a higher incidence of untoward side effects. So I think it's huge. It really is. I mean, it suggests that lower is better. It makes sense, makes epidemiological sense. But getting there is not going to be easy. It really isn't. And I think it's going to probably result in a change in the guidelines, and I would hope to see that.
Great. So a lot of answers from the SPRINT trial, but a lot of questions about how we are to proceed from here as well. Dr. Gersh, what do you think about the trial being stopped early? Should that influence our interpretation of the trial results?
I don't think so. I mean, I've been on the other end of this on a data safety monitoring board, stopping a trial early. You're always criticized. But one has to remember that the role of the data safety monitoring board is patient welfare. And if you feel that one group of patients really is doing significantly worse, then in a way, ethically, you have to stop the trial. So some trials are stopped prematurely and inadvisedly, but here the statistical evidence was unequivocal, and so I think that's why they stopped the trial, and I don't think it should influence our interpretation.
All right. Well, thank you very much, Dr. Gersh, for joining us. For more videos about late-breaking clinical trials at AHA, please visit www.youtube.com/fitsonthego. Thanks.